Focal segmental glomerulosclerosis is a cause of nephrotic syndrome in children and adolescents, as well as an important cause of kidney failure in adults. It is also known as focal glomerulosclerosis, or focal nodular glomerulosclerosis. It accounts for about a sixth of the cases of nephrotic syndrome, is by far the most common cause of nephrotic syndrome in children. MCD and primary FSGS may have a similar cause. Appearance. The individual components of the name refer to the appearance of the kidney tissue on biopsy. Focal only some of the glomeruli are involved, segmental only part of each glomerulus is involved. Glomerulosclerosis refers to scarring of the glomerulus. The glomerulosclerosis is usually indicated by heavy PAS staining and findings of IgM and C3 in sclerotic segment. Classification. Depending on the cause, it is broadly classified as primary, when no underlying cause is found. Usually presents as nephrotic syndrome. Secondary, when an underlying cause is identified. Usually presents with kidney failure and proteinuria. This is actually a heterogeneous group including numerous causes such as infections such as HIV, toxins and drugs such as heroin and pamidronate, familial forms, secondary to nephron loss and hyperfiltration, such as with chronic pyelonephritis and reflux, morbid obesity, diabetes mellitus. There are many other classification schemes also. Pathologic variants. 5 mutually exclusive variants of focal segmental glomerulosclerosis may be distinguished by the pathologic findings seen on renal biopsy: collapsing variant, glomerular tip lesion variant, cellular variant, parietal variant, not otherwise specified variant. Recognition of these variants may have prognostic value in individuals with primary focal segmental glomerulosclerosis. The collapsing variant is associated with higher rate of progression to end-stage renal disease, whereas glomerular tip lesion variant has low rate of progression to end-stage renal disease in most patients. Cellular variant shows similar clinical presentation to collapsing and glomerular tip variant but has intermediate outcomes between these two variants. However, because collapsing and glomerular tip variant show overlapping pathologic features with cellular variant, this intermediate difference in clinical outcomes may reflect sampling bias in cases of cellular focal segmental glomerulosclerosis. The prognostic significance of parietal and NOS variants has not yet been determined. The NOS variant is the most common subtype. Causes. Some general secondary causes are listed below: glomerular hypertrophy, hyperfiltration, unilateral renal agenesis, massive obesity. Scarring due to previous injury, focal proliferative glomerulonephritis, vasculitis, lupus. Toxins. Human immunodeficiency virus-associated nephropathy, heroin nephropathy. There are currently several known genetic causes of the hereditary forms of FSGS. Some researchers found SUPAR as a cause of FSGS. Diagnosis, symptoms and signs. In children and some adults, FSGS presents as a nephrotic syndrome, which is characterized by edema, hypoalbuminemia, hyperlipidemia and hypertension. In adults it may also present as kidney failure and proteinuria, without a full-blown nephrotic syndrome. Tests: urinalysis, blood tests, cholesterol, kidney biopsy, differential diagnosis, minimal change disease, especially in children, several others, treatment, salt restriction and diuretics, such as furosemide, for edema, antihypertensives. If the blood pressure is too high, treat present hyperlipidemia, aldosterone antagonist to decrease proteinuria and thus offer a degree of renoprotection, angiotensin II receptor antagonist, corticosteroids, such as prednisone. Based on the clinical judgment of physician, cytotoxics, such as cyclophosphamide may be used to induce remission in patients presenting with FSGS refractory to corticosteroids, or in patients who do not tolerate steroids. Plasmapheresis, blood cleansing using a machine to remove the patient's blood plasma and replacing it with donor plasma. Vitamin E, fish oil, immunosuppressive drugs, none. Sometimes none of the above works and the patient will require dialysis with possibly later transplantation of a new kidney. Notable patients: former NBA basketball players Sean Elliott and Alonzo Mourning have both survived bouts with FSGS. Mourning is an ambassador to the NephCure Foundation. Pro bodybuilder Flex Wheeler was diagnosed with FSGS and had a kidney transplant. Former Mills player Clyde Sims retired from professional soccer in 2014 due to FSGS. Gary Coleman, American actor, known for his childhood role as Arnold Jackson in the American sitcom Diff'rent Strokes. See also, glomerulonephritis, references. External links: Wei C., L. Hindi S., Lee J., Fornania, Gozen, Sagashima J., Mayagel D., Karumanchai S. A., Yap H. K., Salim M., Zhang Q., Nikolic B., Shotaraya, Daftarian P., Salado E., Torres A., Salafu M., Zawalam, Schaefer F., Morath C., Shvanga V., Ziyur M., Gutta V., Rath D., Rastall D. M. P., Burke G., Ruiz P., Razor J. Circulating urokinase receptor as a cause of focal segmental glomerulosclerosis. NatMed 17, 952 a 960 doi, 10.1038 per nanometer 2411. PMIDA 21,804,539 NephCure Foundation, only organization solely committed to support research seeking the cause of nephrotic syndrome and FSGS, improve treatment and find the cure. KidCom, an online resource for parents dealing with childhood kidney diseases, FSGS research. A team of kidney doctors and scientists from Brigham and Women's Hospital/Harvard Medical School working to learn more about the cause of FSGS and nephrotic syndrome in children and adults, with an emphasis on the genetic basis of these diseases. A general overview of renal pathology: Tehzeb M., Frank R., Gautier B., Valderrama E., Trachtman H. Vitamin E treatment of focal segmental glomerulosclerosis, results of an open-label study. Pediat. Nephril 13, 649 a 52 doi, 10.1007 per second 004670050674. PMIDA 10,502,120 a.